First of all, I want to say thank you, Dr. Gergi, and thanks for everyone to spending such a nice day here. And I think, first of all, I want to welcome to you to this 2019 updates in multiple sclerosis. And like Dr. Gergi said, I'm one of the neurologists working at the MS Center. I joined the MS Center in 2012. It's almost 7 years. Time just fly. And I was able to spend a lot of time taking care of many newly diagnosed MS patients. And if you send an MS patient to our center, probably I will be the one taking care of them and see them in a fast fashion there. And 2019 is a great year for neurology, and 2019 is a great year for MS. We have 2 newly approved MS disease-modifying therapy. I'm going to talk about quite a bit in details today about those newly approved treatment. And also I'm going to talk about some updates on the treatment we already knew. And as you can see here, I love to talk about MS, and this is my passion. And many young people, especially, I was able to have the privilege to take care of so many newly diagnosed MS patients. So as you can see here, it's a very good learning experience for me all these years. I think you all know the prevalence of MS increased quite a bit over the years, especially with the powerful diagnostic tools, the awareness all these days. I do think we were able to diagnose MS patients much earlier, and with National MS Society's support and then community neurologists' help, and even primary care doctors, we are able to get our patients in MS neurologist clinic much faster these days. So I think this is a great news for our MS patient, and we are able to control their disease activities much better, and hopefully prevent disease progression and decrease amount of disability in these patients. So as you can see, the estimate of MS prevalence in U.S., this is ever changing. Every day we have more patients diagnosed. In 2017, as you can see here, it's about 947,000. And this is increasing 6.3% in lifetime prevalence from 2010 to 2017 here. Female to male ratio is still about 2.8 to 1. About 100 years ago, actually, we have more male patient to female patient. Some of this could be because of medical access, and but these days, I think it's the powerful diagnostic tool with the MRI, with the awareness, we are able to make accurate diagnosis much earlier these days. So, the McDonald MS diagnostic criteria updates periodically. In 2017, we have a new diagnostic criteria. This new diagnostic criteria definitely help us to make diagnosis more accurate and also quicker and sooner for our MS patient there. So several updates here and a new thing. CSF study counts towards disseminating in time. If you have more than 2 oligoclonal bands in the CSF study, that can be used in the criteria, so-called disseminating in time. We used to need to wait for 2 episodes of neurologic condition episode to fulfill the criteria of disseminating in time. But now if you only have 1 episode, but you have 2 lesions in the brain or the spinal cord, you can use a positive CSF study to fulfill the diagnostic criteria in time, so-called disseminating in time. I'll give you an example later on here. So symptomatic lesion also can be counted as disseminating in space. Used to be only asymptomatic lesion can be used, but we notice more and more that those symptomatic lesions could definitely enhance the sensitivity and also do not compromise the specificity in the diagnostic criteria. One caveat here is the optic neuritis lesion on the MRI is not counted towards disseminating in space, mainly because, especially elderly patient, if they have some quite non-specific brain lesion there, if you just use optic nerve as a disseminating in space, that might decrease the specificity. That's the only concern we have, but you can use the other lesions for disseminating in space. Cortical lesions these days can be used to fulfill the juxtacortical or subcortical lesion. And we also recommend in this new diagnostic criteria, recommend patients to be evaluated periodically, active versus non-active. This is a hard thing because some of the patients, for example, can be in remission for a long period of time, and then they can all of a sudden have a relapse there. So depending on disease course, overall, this is relative active versus non-active. We try to use the words worsening in relapse MS patient and trying to use the words progression in primary progressive and secondary progressive MS patient. as you see, the progression, some of the patient could progressing from day one. And also, ultimately, the question is, what's leading to those progression? Some of the patient can have other comorbidities. Some of the patient have other neurologic condition and can all present similarly. So we need to be careful to tease out what's really causing those progression in those MS patient there. Primary progressive MS patients diagnosed criteria pretty much remain the same here, but we can use symptomatic lesion and non-symptomatic lesion at the same time to fulfill the disseminating in space. Misdiagnosis is still a big topic here in MS field. As you can see here, many people presented typical MS symptoms and have a very typical MI findings. Some of the patients are not, especially people with late onset atypical presentation here. So we try everything we can to make sure we rule out all these other MS mimicking disease. MOG, antibody-mediated disease, neuromyelitis, optica spectrum symptom should be considered, especially people with bilateral vision loss and significant findings on their spinal cord with longitudinal extensive transverse myelitis. All these red flags should help us to understand if there's anything else we need to search before we're giving them a clear MS diagnosis here. As you can see, we use CSF study result, a positive result, to help us understanding these diagnosis. Usually, it's not specific. That means even if you're positive, doesn't mean you have MS. But if, on the other hand, if it's negative, doesn't really rule you out from this condition. But definitely in those non-classical presentation, a positive CSF study, you can now use that to fulfill the diagnostic criteria of disseminating in time. So this is quite helpful. This is a busy slide. It's probably too small for you to see, but this is a very nice one put together by the National MS Society. You can just go to the website. You will be able to get these cards easily. And I think it's a quick reference there. When you see a patient and you say, well, this patient had one relapse, for example, just right here. You can go through this each scenario here. For example, in this one is just one relapse. Patient had two lesions, one in the juxtacortical area, one in the paraventricular area. Patient clearly had a very classic presentation of MS symptom, but only one relapse. What else do we need to make MS diagnosis versus, we can only call this clinical isolated syndrome. So you can see in this card, they will be able to tell you. You can use several other things to fulfill the so-called disseminating in time when patient only had one relapse. What are they? So in these slides, as you can see, if you have additional attack, you can fulfill the DIT, disseminate in time, of course, but we don't want to wait for the second event. If you have an enhancing lesion and a non-enhancing lesion at the same time, or if you have a baseline MRI somewhere before, like 2 years ago, now you have a new lesion compared to the previous lesion, either enhancing or non-enhancing, or you have a positive CSF study, you can fulfill this diagnostic criteria of disseminating in time. So you can see we can use this new criteria to make a diagnosis of MS much quicker. So this is really helpful. You can have that as a quick reference, and sometimes, especially when you have a patient not quite sure, we can understand much better. In terms of MRI in MS, we use the CMS-C guideline here quite often to help us to know when is the time to use the MRI scan again to monitor our patient, and when to use like gadolinium. Enhancing lesion is very helpful in terms of understanding patients' disease activity, no matter they are already started on treatment or this is monitoring disease progression when you are thinking about switching a treatment. And also ultimately to rule out some other presentations or atypical presentation that wonder that's really a MS relapse or there's something else, especially with those atypical or unexpected rapid clinical worsening. I think MRI images especially helpful. For example, I have a patient myself. She has clear-cut MS. She's a 63-year-old African-American lady, and she had an enhancing lesion after many years of stable disease. So that lesion is in the juxtacortical area, and that is reported as a MS enhancing lesion there. So, but it's quite, she doesn't have quite a bit new symptom, but she's losing weight. And she's an African American, otherwise quite stable for many years. This lesion doesn't look, can be seen in MS. It's a ring enhancing lesion, but had a little bit of heterogeneous enhancement there. So I'm not too happy. I only saw this patient the first time, but she just had this MRI 2 months ago. When I saw that images, I was not quite happy with that lesion, and I'm concerning with her weight loss and her smoking history. So I did this repeated image right away. As you can see, I have to fight with the insurance company. Turns out this is a metastasis from her lung cancer. So as you can see here, the next time the lesion is much bigger, just after 3 months. I do think this is very helpful usage with gadolinium to help out, overall getting a accurate diagnosis and also understanding the disease progression here. Many patients have concern about GAD. They usually ask us, I can have a repeated brain MRI, but do I have to get GAD? So the CMSC guideline here is usually ask us to be careful because gadolinium can stay in our nervous system here. We need to use it judiciously and recognizing that GAD to play an invariable role in specific situations there, in diagnosis and a follow-up there. Usually, if you start a patient on a new treatment, we recommend you to do this every 6 months to 2 years based on the disease activity. And after that, we pretty much can slow down, space out a little bit, especially with GAD. If patient's stable, we can use those overall T2 lesion load change to understand the disease progression. And we don't necessarily have to use the GAD after 2 years, always prolonged stable disease course here. I think you also probably should know many times more often is can you do MRI if you have a specific like a deep nerve stimulation, deep brain nerve stimulation or some kind of pacemaker. These days, I think our radiology colleagues are very careful to help you assess that. So when you're not sure, always ask people about this card they carry in their wallet if they have a deep brain stimulator or a pacemaker, nerve stimulator in their spinal cord. Make sure you get that information. Make sure you present this, ask the patient to present to the radiology colleagues so they can have the final say on this. And many times they need to turn off their device or they need to, even sometimes they can remove that if they don't really need that. Can help our MS patient understand much more how safe it is for them to get MRI or if they are able to get MRI at all or not. All right, so the guideline for CIS I think is very important because patient had just one isolated syndrome with GAD enhancing lesion on the subsequent images could be very helpful to confirm that diagnosis here. So GAD is essential for following patient with highly active disease, as you can see here, especially when you have very large lesion load. When you have almost 50 lesions, if you just have 1 or 2 lesions, it can be embedded in those large lesion load. It's very hard for you to tell if you have one new lesion or not. But if you have an enhancing lesion, it's very easy to see that one shiny lesion there and in the large background lesion there. So if you have rapid decline of your function level, but it's unexplained or unexpected, like we got from the previous example I was just talking about, I think it's very good use GAD in that situation. And also, if you're concerning alternative diagnosis, some patients can have other inflammatory condition in the brain, and I do think these are important. Sometimes when they're not clear, we usually get more, such as systemic sarcoidosis is common mimicking disease for MS. So we need to make sure we do use other imaging modality to help us understand their other differential diagnosis there. It is an optional choice for people with stable disease, like we just discussed. And I think we will need to know more about long-term safety, about GAD use in those patients there. Today, I'm going to talk about several updates here. As we said, there are 2 newly FDA-approved treatment for MS patients, including CIS and actually active secondary MS patient. I'm going to also talk about some updates about rituximab, lipoic acid, opistinolimab, basically anti-LINGO-1, a potential remyelinating agent. I'm going to talk about vaccine in B-cell depleting treatment when patient getting Ocrevus treatment. How about their vaccine the humoral response, is that going to be affected or not? I'm going to just briefly talk about some potential future B-cell depleting treatment in the clinical trials. There are several of them, and I just want to also mention the first FDA-approved disease-modifying therapy for neuromyelitis optica spectrum disease with a positive alcoholin-4 antibody there. So this is quite a bit of information, so I try to jump right on into it. First, I think this is a study we did in Sweden. This is a study to compare the efficacy and basically retention of disease-modifying therapy in rituximab-treated patient versus other disease-modifying therapy. As you can see, in Sweden, they have a lot of MS patients. They also use heavily on rituximab. You can see here, about a quarter of them patient was on rituximab treatment because certain, I think, payers in part of the country just allow rituximab as a first-line disease-modifying therapy in those patients. And this is in 2 areas, Sweden, and the other part of the country, they use more diverse disease-modifying therapy, including oral treatment and the infusion treatment and the injectable therapy as well, pretty much like the US here. So they want to compare the discontinue rate and also the reason why they discontinue that. So in this slide, you can see on the top line, the red line is the rituximab. Definitely you have a better retention of those patients on those treatment compared to the other one, including the oral treatment and the infusion injectable therapy. This is the reason for patients to continue the disease-modifying therapy over the years. As you can see, the first panel is rituximab. On the right is injectable. On the bottom is dimethylfumarate on the left and natalizumab on the right. Most people continue on the treatment here. As you can see, people really have much disease breakthrough on rituximab. On the injectable, I think the most common reason is disease progression, some of them due to side effect or the lab problem. On dimethylfumarate, as you can see here, similar thing, adverse event and disease breakthrough, and some of them due to abnormal lab result. On natalizumab, I think the most common reason for people discontinue is positive JCV antibody, which is a risk factors for patient develop future brain infection. So that's a main concern for those patients. So lipoic acid, a large dose lipoic acid, about 1,200 versus placebo study is being done. This is a preliminary, the pivotal study, 51 patient, secondary progressive and the primary progressive. The primary outcome is the annualized percentage change in brain volume. As you can see here, it's a pretty significant difference between the treatment group versus the placebo here. There is some GI side effect, and one case of renal failure has been reported in this study here. So ongoing phase 2 trial is still recruiting more patients, including our Swedish site, and we want to recruit patients with EDS less than 6.5, basic people using walker or 2 walking sticks there. And we want to know basically the outcome measure. The primary outcome is the disability progression here. So you can see in the previous study here, we can see the brain volume reserve with lipoic acid here. We want to see we can repeat that result in this phase 2 trial. So the next one I'm going to talk about is siponimod. Siponimod is a newly approved oral treatment for MS patient. Actually, it's a large spectrum, I call it. It's approved for CIS, relapsing remitting MS, and active early stage of secondary progressive MS here. Fingolimod and the siponimod, they have a lot of similarity here. They are both so-called SP1 receptor modulators. Fingolimod, which has been used many years, it's on the modulator on the receptor 1, 3, 4, 5. And siponimod is more selective. It's on receptor 1 and 5. So what's the difference? So you can see on this picture is the SP1 receptor modulation. You can see you have all these receptors there. And S1P1 is mainly on lymphocyte. And also we can see them in the atrium, the myocytes in the heart. And also SP15, it's mainly in the oligodendrocyte in the central nervous system. And also some natural killer cells. When you target these receptors specifically, you can have these effects, so-called lymphocyte egress from lymph node. So we pretty much prevent those lymphocytes leaving the lymph node here. And also we can have some central nervous system cell function and migration effect by using this SP1 receptor modulation therapy. And also we can have some vasomotor tone and heart rate effect because the expression on the heart. So as you can see here, siponimod is a selective SP1 receptor 1 and 5 modulator here. It has a fast immune reconstitution, basically has a half-life of about 30 hours with a short washout about 6 days. And this is a specific SP1, SP5, as you can see here, so mainly working on the lymphocyte and the central nervous system. And has this effect inhibiting action of the lymphocyte, basically leaving the lymph node to cause trouble, ultimately reduce inflammation in the central nervous system, and hopefully, and also promote repair, CNS myelin repair for MS patient here. So this is a busy slide. Basically, you can see the T cells entering the circulating in the blood was able to searching for foreign antigens. So they entered the lymph node from the blood. And then when they have this SP1 receptor on the surface part of the T cells, they are able to migrate towards the outer zone, the sinus lining endothelium, through that path to leave the lymph node, enter the bloodstream here. With siponimod, they can cause internalization of those lymphocytic S1P receptor on the surface of T cell. So they go inside, so these cells will not be able to migrate out of the lymph node easily. Many of these T cells, we think they are the troublemakers. So by preventing them leaving the lymph node, is enter the bloodstream and entering the central nervous system, we can hopefully reduce the MS-related inflammation in the brain. So as you can see here, this could be associated with a visible reduction of circulating lymphocyte in the blood here. What's the difference between fingolimod and siponimod here? And you can see here, siponimod is more specific on receptor 1 and 5. It's not a prodrug. Fingolimod needs some phosphorylation before it becomes an active drug, and siponimod is not a prodrug. It has a shorter half-life. Basically, you can wash out quickly. Decrease in heart rate, both siponimod and the fingolimod can have that. Siponimod probably nadir faster, about 2 hours, and fingolimod lasts a little bit longer. The nadir is about 4 or 5 hours. Blood pressure change, both of them can cause a little bit change after first dose, and there's a decrease in absolute lymphocyte count in both of them, as you can see, mostly as dose dependent at day 7 in siponimod patient here. So as you can see, this phase 3 trials, so-called EXPAND study, is a study to see if siponimod had any effect in secondary progressive MS patient here. This is a large trial, more than 1,600 SPMS patient. Many of them still have some gadolinium enhancing lesion and active disease activity there. Their average, the EDSS between 5 and 6.5 here. This is a study of up to 3 years. Many patients, as you can see, they are 2-to-1 ratio. This is a placebo-controlled study, so 2-to-1 oral siponimod versus placebo. The primary outcome is 3 months clinical confirmed disease progression here. Yes, as you can see, 26 siponimod versus 32% placebo patient reach this primary outcome there, and this is 21% relatively risk reduction. And also the 25 feet walk time is decreased about 25%, is similar between both group here. They also look at the safety, lymphopenia, increased liver function, bradycardia, all those side effects in both group here. In this picture, as you can see, the 3 months clinical confirmed disease progression. The green line is siponimod, and the I think the blue line is the blue line is the siponimod group. As you can see, this line separates after 6 months and more so after 12 months. This picture showing on the left is basically the 3 months, and on the right is the 6 months disease progression. As you can see, people on the siponimod, the blue line, doing much better than the placebo arm, which is the red line there on the top. And they notice certain group people, the frequency of responders definitely indicating or favor siponimod group than the placebo arm. The secondary outcome is the detailed measurements such as 25-feet walk, annualized relapse rate, and their change in T2 lesion volumes, and all these get enhancing T1 lesions. You can see the significant difference between these two groups, between the siponimab group and the placebo arm group, except the 25-feet walk, which is not quite a significant difference. The important thing, probably take-home message for siponimab here is we need to do a genotype testing before we can start siponimab. Why is that? Because this medication need enzyme, so-called CYP2, C9 enzyme. There is some kind of heterogeneity in this genotype. As you can see, majority of the patient could be in homogeneous one, the so-called star 1, star 2 genotype. And this half-life of siponimab in that group of patient population is about 28 hours, but it increased in those star 2, star 3, and much longer in star 3 and star 3 genotype there. So it is recommend do not give patient siponimab if this is star 3 genotype there. And the dose should be adjusted in star 1, star 3, or star 1 and star 3. If you're at star 1, you're perfect. You can just have the 4 dose, no just those adjustments. How about first dose observation? That is the common question here. So this first dose, 6-hour monitoring is still recommended for patients with sinus bradycardia, usually less than 55 at baseline. If they have first or second degree of AV block or any history of myocardial infarction or heart failure, we need to be more careful. If they don't have that, you don't have to do these first dose observation here. All right, this is about siponimab. I'm going to jump to epinephrine. This is an interesting name. Basically, it's a name for anti-LINGO-1 molecule. What is LINGO-1? LINGO-1 basically is a molecule we notice in many animal models. It's an inhibitor of potential remyelination, or basically oligodendrocyte precursor cell to differentiate, produce more myelin sheaths. When our brain is fully developed, we just inhibit this signal so they don't keep differentiate over time. But how about MS patient? When they have this damage, when they have this oligodendrocyte loss, we want to produce more myelin sheaths there. So in many in vitro study, we notice LINGO, anti-LINGO. Basically, you block LINGO-1 with anti-LINGO-1 antibody, they can facilitate external myelination in vitro and also have potential remyelination in the in vivo models. Many models showing that they have enhanced, after you block LINGO-1, you can have enhanced differentiation of oligodendrocyte precursor cells. So with that, we move forward with phase 1 and phase 2 studies to see if anti-LINGO-1 can help MS patient reproduce the myelin protein, and also ultimately is improved in their functions, disability levels. So as you can see here, the phase 2 failed to reach this primary outcome, which is the improvement in their neurologic functions, disability level. But in this picture, as you can see here, there's different dosage we use in the trials. There are lower dose and a much higher dose on the right. Only these two here in the middle, which patient clearly experience favorite result. The odds ratio is indicating that these two dose patient clearly is better than the placebo arm here. If you further out favors the treatment, this is the placebo arm. So ongoing phase 2 trial is still recruiting patients. Actually, they're done with recruiting. They still observe those patients and with extension to prove the concept whether this potential remyelinating agent can help our MS patient to reproduce myelin sheath protein here. All right. So next, I'm going to jump into the vaccine and the ocrelizumab, the B-cell depleting treatment. You probably got quite a bit of questions. Can I get my vaccine? When should I get my vaccine if I receive B-cell depleting treatment? And this study is done on patients receive ocrelizumab, and they studying the flu shot vaccine effectiveness. 3 months later, 12 weeks later, after they received their first dose of ocrelizumab, they give patient the vaccine, and they noticed a decrease response, the human response, if patient received ocrelizumab compared to the comparison arm. So we need to be careful in this. And as you can see here, this is the tetanus vaccine. You see the same. The blue line is ocrelizumab compared to the placebo arm. They have decreased effect, humoral response there. Proportion patient is a significant difference compared to the placebo arm, which is only receive interferon. or no disease-modifying therapy. This is pictures I like to share with you. This basically show you a CD20 surface antigen domains that in the surface of B cell. Many B cell depleting treatment target specifically into those epitope. We know we have rituximab. You can see the blue ones are the rituximab epitope we recognize. This overlap with ocrelizumab. So rituximab, ocrelizumab epitope recognition is very similar on the surface of the B cell. Oblate, which is another B cell depleting treatment in the clinical trial, overlap the rituximab, ocrelizumab epitope with the green one here, and also another one. Tumor Map, which is also a B cell depleting treatment, recognize a different domain here in the under CD20, but they all cause the final step, depleting B cell by recognizing the B cell surface marker and remove B cell from the bloodstream here. So I would like to focus on the two B cell depleting treatment. One is called Tumor Map. This is a humanized monoclonal antibody against a CD20. And there are two identical phase 3 trial has been done and was up to 30 months of follow-up involving more than 1,800, close to 1,900 MS patients with relapsing form MS. So they are randomized into sub-Q injection monthly of a Tumor Map self-administered injection versus 14 milligram teriflunomide, which is a daily oral dose, up to 30 months. They noticed that Tumor Map can significantly reduce the annualized relapse in relapsing MS patient, and also it met some secondary endpoint there. This study result was just reviewed a week ago in the MS Society meeting in Europe, and we will be waiting for the final detailed result about safety and other detailed information there. So this is encouraging and, about Tumor Map. Oblate is an interesting name, is also a B cell depleting treatment. It's a chimeric one, basically. It's not a humanized monoclonal antibody. But it's glyco-engineered antibody, which much enhanced ADCC, the antibody-dependent cellular cytotoxicity there. They said in the in vitro study, this activity is much higher than rituximab and Tumor Map there. So as we see here, it targets a specific receptor epitope on the CD20 cells. In the phase 2 trial, they studied this drug infusion in a rapid 1-hour fashion, and noticed that most of the patients can tolerate this treatment with only 1-hour infusion. The ongoing phase 3 trial, also compared to teriflunomide, is still going, and we will be able to know the result in the near future about this B-cell depleting treatment. Next, I'm going to talk about a newly approved oral treatment called cladribine. Cladribine is now approved as a first-line, as the first and only short-course oral disease-modifying therapy for active secondary progressive MS and the relapsing remitting MS patient. As you can see, due to safety reason, it's not approved for a first-line usage. This treatment has a unique feature here. What is cladribine? Basically, it's a nucleoside metabolic inhibitor. It substituted the hydrogen, substituting a chlorine atom, as you can see here, for a hydrogen atom. So it will be able to avoid the degradation from ADA, the adenosine deaminase. So we'll have a higher intracellular level for this treatment. It will enter the active B cell and T cells, and then it will go through phosphorylation into its active form. And when it's active form, it will incorporate into the DNA synthesis. Because of the chloride substitute, it will impair the DNA synthesis, which may lead to the depletion of B cells and T cells. As you can see, when you do those, this is a 2-year treatment. You only use a short period of time in year 1, about 5 days, 2 months apart, month 1 and month 2. And then after a year, you will do those course again, basically month 1 for 5 days, and then month 2 for 4 or 5 days. As you can see, a dip of lymphocyte count after this first round of treatment, and the second year, you have another dip of lymphocyte count. We need to monitor those lymphocytes carefully before the second year treatment, make sure it's in certain range before you give them the dose again. In the clinical study, we know this decreased annualized relapse rate about 58% compared to the placebo arm. In the MI data, you know, this T1 get enhancing lesions about 86% decrease, and the relapse, the total T2 lesions about 73%. So this drug is based on body weight. And we will separate the dose in 2 years, and each year you will have a short treatment course in months 1 and months 2. Usually you have 4 or 5 days in months 1, then you take a break, and then months 2 you repeat the same dose, and then wait about 10 months to the next year to have this second course. FDA do not recommend continue second course if you do the lymphocyte remain low there. There are some malignancy concerns, especially with the global data. In the U.S., we have limited exposure, so we can see here we don't have much patient years compared to the rest of the world. And these malignancy risk is about 0.27 per 100 patient years. And the U.S. population is a little bit higher, but we have limited exposure, so long-term safety data is definitely very important for this treatment here. What's the common malignancies? It usually is pancreatic, melanoma, and ovarian cancer. We've noticed in the clinical trial. So last, I'm going to focus a little bit about the neuromyelitis optica spectrum disorder with a positive equipoint-4 antibody. In this group population, we were able to study the eculizumab. It's a monoclonal, humanized monoclonal antibody which targets the terminal complement protein called C5. When eculizumab binds to this C5 complement, it will prevent its cleavage to C5a and C5b, which both have potent pro-inflammatory effect. Also, they coordinate the formation of membrane attack complex there. So by using the eculizumab, we hope we will be able to control the inflammation there. Eculizumab is not new. It used to treat this atypical hematolytic uremic syndrome and paroxysmal nocturnal hemoglobinuria. It carries a black box warning because of risk of meningococcal infection there. So as you can see, FDA, after its approval, they recommend we give patients meningococcal vaccine before, at least 2 weeks before we start the treatment for our neuromyelitis optica patient there. So here's the slides about the efficacy of eculizumab. It's a busy slide. You can see the blue line is eculizumab. The red line is the placebo. This is placebo-controlled study. The primary outcome is the first adjudicated relapse. Basically, they want to know how soon people reach to their first relapse. Compared to the eculizumab-treated group, most of the placebo-controlled patients start to having relapse there when the eculizumab treatment group stay pretty well in this study. As you can see, this study allows patients to take other immunosuppression treatments such as oral immunosuppressant, Imuran or Cellcept. They compare those two groups. People do have concomitant immunosuppression treatment versus people do not take any other oral immunosuppression treatment. They still notice the effect there. This is people do not take any other oral immunosuppression treatment, and this is the one taking other oral immunosuppression treatment there. So you can see this line still separates, indicating the benefit of eculizumab use. There is some caveat with eculizumab. So yes, you can see many of our neuromyelitis optica patients take rituximab. Rituximab was also through a complement-dependent cytotoxicity there. This CDC, the complement-dependent one, will be 90% inhibited by eculizumab because it targets the terminal complement there. Also, this study only studied on the equipoint-4 antibody-positive population there. So we cannot extrapolate this study result to the negative antibody, equipoint-4 negative antibody population easily there. They don't have a long-term follow-up on those patients. They only follow them 6 weeks after their first relapse there. So long-term follow-up data is definitely needed to also measure their disability progression here. This trial, many of them have other immunosuppression use there, but it seems like people either use that, use the oral immunosuppression or no immunosuppression use, they all have similar result there. So in the future, because of its effect and the risk of meningococcal infection, we do recommend monotherapy. We do not recommend, basically FDA do not recommend using those together. with that, I think that's all the slides I have. I went through very quickly, and I'm more than happy to answer any question if you have. Thank you very much for your attention.